Professor Coiera is the foundation professor at the Medical Informatics at Macquarie University, director of the Center for Health Informatics, and the director for NHMRC Center of Research and Excellence in Digital Health. Sidebar, this doesn't count as one of my sentences. We live with acronyms, so we'll have to put up with that. Professor Coiera spent 10 years at the prestigious Hewlett-Packard Research Laboratories in Bristol and has overseen the development and trial of multiple e-health interventions. So those are my two sentences. I hope I have done as instructed, and that now provides greater time for the professor to share his wisdom with us, and there will be time for questions following that. So, Enrico.
Well, good morning, and it's a great pleasure to be here. I realised after that wonderful welcome that what's missing from my talk is hand actions. So for the next time I do this, I will have incorporated some movements to make it a bit more lively. The topic of this morning is artificial intelligence, and it's one that I've lived with for a long time. And my hope is that in the talk this morning, I will bring you a more clinical perspective on AI rather than talking about the technology. There's much to be excited about AI. There's also much to be, I guess, considered about or concerned about it. There are also, I guess, so many unknowns in terms of its impact on clinical care and medicine and healthcare that a lot will unfold over the next 2 decades. So let's just, I think, step back and look at the narrative maybe of the last 2 to 3 years. We all use AI every day. If you've got a smartphone, your Facebook feed is tweaked by machine learning. If you've got Netflix, the movies that are recommended to you are based on machine learning. Your Google search is customized to you based on machine learning. So people very quickly realized that something big is happening because these major businesses are all driven on AI. And it didn't take long for people to start to get excited, I guess, about the impact of machine learning in healthcare. And the area where most excitement has been in the last 2 or 3 years has been in imaging, so especially in radiology. The results that are coming out of machine learning and radiology are quite astounding, really, compared to where we were a few years ago. And people have started to think, well, this is not just technology that's exciting. What does this mean for healthcare? And people started to think, well, maybe machine learning will be able to help radiologists do their job better. But that dialogue very quickly moved on. Maybe it's AI versus MD. Maybe the AI is going to make us redundant. Maybe computers will take over. Radiology won't exist as a profession anymore. Perhaps let's not stop there. Maybe dermatologists don't have a job anymore. That's just looking at pictures of moles. And if you're an ophthalmologist, that's just looking at pictures of retinas. So maybe those disciplines are gone too. Very challenging thoughts for all of us. Yet the reality has been a bit more difficult. So if you've been following what's going on, IBM Watson has had a big splash in healthcare with a big focus on oncology, and the last couple of years have seen some very large contracts be cancelled because what was promised and what was delivered were very different things. If you've come from or been following what's happening in the UK, there's been a very interesting saga for a company called Babylon, which not just provides primary healthcare, but has a telehealth service, and the front end of that is an AI, what they call an AI, for symptom checking. And it's very clear that AI or symptom checker doesn't always work as recommended. Often misses very obvious presentations, PEs, infarcts. It doesn't do a good job. It's still licensed and available, but there's huge concern about its performance. The thing that's most intriguing for me about Babylon is that despite the AI being not necessarily ideal, it's already changing clinical practice. So we're seeing very healthy young Londoners going to join the Babylon, and of course they don't really need much care, and so they go off the books from GPs, who then are left with a smaller cohort of people who are more chronically ill, and so that affects the cost basis of primary care in London. So already we're seeing AI in whatever form affecting quality of care, affecting the business models of healthcare, and that's just going to continue. So let's look at the story, I guess, from the beginning. And this is a slide with a bit of a chronology of AI in healthcare, just in case you thought this was invented 2 years ago. In fact, it started with two physiologists who invented the well-known model now of the neuron, McCulloch and Pitts. And then over the years, really, we've seen some major things happen. I've got to put my glasses on here because I cannot see what's going on. So you can see that there have been lots of advances, but also many setbacks. I'm highlighting there a famous paper by Marvin Minsky, who was an MIT computer science professor, who essentially said neural network models didn't work. And so that was really the end of research in that discipline for 2 decades. There was also a very famous report called the Lighthill Report that came out in the UK that said, the world market for AI is about 3, so let's not bother doing that. So then again, the end of research in that part of the world. The world of AI in medicine has been active really now for over 20, 25 years. In fact, that book on the left-hand side there is the book that I first bought when I started my PhD in AI after my medical degree, and that was sort of in the early 80s. So there's nothing new here. There are some interesting changes, which are that computers are far more powerful and cheaper than ever before. The other big difference is that data is available in volumes that we've never had before because of digital records. So there are some issues which have kind of made it commoditized and powerful, and there have been some changes in the technologies, but not what I would call radical if you take the long view. So the question really is then, we've gone through these cycles of boom and bust, and are we now heading for another AI winter? Is Watson and Babylon, are these heralding the end of AI for the next 5 or 6 years? And I think my answer to you already is no. There are challenges ahead, but it's here to stay. And I think this is going to be the first great period where AI starts to change healthcare. But we'll talk about that during the morning. So just to give you a sense of what's happening around the world, England has really amazed me with the level of investment that's happening in the NHS there. So over £1 billion by the NHS has been invested in translational activities associated with AI. That's a lot of money. And they've got a very ambitious goal of reducing cancer deaths by 10% over the next 15 to 20 years through automation and better diagnosis. Lord Darzi had a review who said that 10% of the NHS's budget, a lot of money, might be reduced through automation. So clearly where issues are around cost and sustainability of healthcare, people see automation as a panacea, rightly or wrongly. You can see there also a huge investment in research, and I know that UCL has just been given one of those large centres for AI training. So a lot's happening just in England, and if you think about what's happening in Australasia, New Zealand, we're really not on the map. I don't know what the situation is in Canada. Just some other facts and figures, just to show you the numbers that are going on. China is going to be $150 billion AI enterprise, they say, over the next decade. And I think that's true when you think about its impact across the board, not just healthcare. I love this. The US government is spending about $1.2 billion on AI, but then MIT alone is investing $1 billion in a new school. And the numbers I don't have there are what is Apple spending, what is Google spending, what is IBM spending. So you can just add the billions. This is really happening at industrial scale everywhere. And it's touching our lives as consumers. The question for us today really is, what will it mean for healthcare? So I know for those of you who were here yesterday, you had a wonderful introduction to AI and machine learning. I'm not going to repeat that. But for those who weren't here, here's just a few highlights about the language that we use. And if you've been reading about it, you'll often hear the term deep learning. This refers specifically to a class of technologies called neural networks. And they're called deep because they just have stacked a few more layers on. So it's not really deep, it's just more layers of neurons. But deep learning is only one tiny part of what we mean by AI. It's just a subsection of a discipline called machine learning, which is all about being able to get lots of examples of events in the world. For example, here are a lot of chest x-rays with pulmonary nodules. I've got a classification for them. These ones have the disease, these don't have the disease. And there are so many different methods apart from neural networks to be able to learn those classifications. But AI is not just about learning, it's about other tasks. And so if you think about the challenges of what we encounter as humans when we think about intelligence, we do lots of other things. We plan, we adapt, we reason from first principles. You know, you might think through physiology when you encounter a patient. You don't just say, well, I've seen one of these before, I know what's going on. You have an understanding of mechanism. All of those things fall well outside of the space of machine learning. There are other things. At the moment, they're not getting as much attention, I guess, because deep learning has made such a major inroad in the last few years. And the bit that I think is most interesting, and I always say to my students, if you really want to go to new territory, it's to examine the world of what it's like for humans and machines to coexist. So human-AI interaction, what do those models look like? This is really unknown territory. If you imagine it's got, Siri is a fairly frustrating interface. Siri do this, Siri do that. What would it be like to have an AI that was a part of your multidisciplinary team? Or sitting next to you in the primary care as you saw a patient? How do you design that interaction? What will be intrusive and not intrusive? So those things are all yet to be unpacked. Now, just to give you another sense of where AI applies and what it's good at, this is a non-technological view. This is simply looking at tasks. So I've just broken things up into what I'm calling context-specific, which might be a GP office, versus context adaptive, which might be I'm able to look at X-rays in an urban setting as well as X-rays in the city. So in other words, adapting through different contexts, and then whether the AI is good at just one job or can do many jobs. And if you look at that top left corner, that's really where a lot of the current activity has been. Here's a machine learning algorithm that's great at interpreting exactly one disease in CT scans, or here's a melanoma detecting AI. Or this is where all our traditional analytics so-called fits. Context adaptive is actually one of the great benefits of AI. So this is where you can learn one task and then merge another task. So it's actually, for example, surprising, but let's say you learnt to interpret X-rays in Sydney at 2 or 3 teaching hospitals. You would take that system to even Melbourne, and you would find that it wouldn't work as well because of small differences in populations. So we have to do something called transfer learning to make sure that we adapt to that population. A funnier example, which I think is kind of telling, is that one of my colleagues in the States was trying to learn how to interpret a set of CT images of the chest, but didn't have many examples. And so he thought, what can I use? So he went and found a neural network that had been trained to recognize cats. And then he retrained that network on the CTs, and of course it worked very well. And you think, well, cats have got nothing to do with CTs, but what that algorithm had learnt was how to interpret images. So it knew what a line was, what a circle was, what texture was, and then the final layer was what the images meant. So transfer learning is a very powerful way of adapting across contexts. That bottom left-hand corner is where we reason about multiple different tasks. And a good example of this would be being able to, I guess, look at the literature or look at multiple examples and reason at first principles what's going on. That's an area where AI is very poor. It's an area of active research, and it's something that's not going to happen for a long time. The bottom right-hand corner is science fiction. This is AGI, Artificial General Intelligence. This is the AI standing up here and giving you a talk and answering your questions. I don't know how to build that AI. I haven't seen that technology. Anybody who tells you the singularity is coming and the robot overlords are coming is probably 10 to 20 years away. Hope my kid's going to be okay. It might be a lot longer than that. So it really depends on fundamental changes in our understanding of building AI. We're not anywhere near that yet. So to summarise, today's AIs are fantastic at single tasks. Very good. Give them a set of examples of a single task, like interpreting TB nodules in a chest X-ray, and they'll be brilliant at that, better than you. But they will struggle at reasoning across multiple tasks. And as I said, the AGI is a long way away. Okay. Just to give you a sense now of benchmark performance, here are just some recent graphs of AI performance. This one here is the Where's Wally task. This is, can I detect an object in a set of objects very quickly. More sinisterly, it's a camera looking down the street, looking at faces and identifying who you are. You can see that line crossing the red human line several years ago. AI is much better than us at image interpretation. It's just beaten us hands down. This one here is speech recognition, and it's showing AI equal to human speech recognition. That's not really true. That's great if we're talking about a single speaker on a telephone or you on your mobile phone. We're, for example, in our lab looking at being able to interpret conversations between patients and general practitioners. And the moment you have two speakers, that recognition goes right down. It's very hard in that setting to know who's saying what and why. So that's still a little bit further away than those graphs would show. Bottom left-hand corner is question answering. So instead of typing in a search to Google, you would say, Google, what's the capital of Peru? And you can see here that in general, that requires knowledge about the world, that reasoning across multiple tasks, and AI is not quite approaching human capability. If you want to laugh, you should look at the research on explaining images, what's going on in the image. Often you'll just move an object a little bit and it'll classify a computer as a cow because it's changed context. So AIs are very bad at explaining what's in an image. Again, if you think about it, it's because it requires understanding of what's happening in there, and that understanding issue is still a challenge. Okay, so one of the themes I was asked to explore today was the issue of trust, and should we trust AI? And I think the first way I would like to tackle that is to look at the issue of ethics and AI. In other words, what are the ethical rules or rules of the road for AI? And I would recommend, if you want to look at an example of those road rules, the College of Radiologists have published a very nice set of ethical principles, and so I'm going to have a look at that. I've got up here Asimov's rules, and if you're a science fiction person, you know what these rules say. They say, if you're a robot, don't kill humans, please. Do what you're told. Don't hurt yourself. And if your master says to destroy the planet, please don't do that. So they would seem very obvious basic rules that any AI would follow. Unfortunately, I don't think those rules, by and large, hold in healthcare, because we cross those lines every day. Here's a wonderful paper by one of my old colleagues, Ken Hillman. Ken's very interested in end of life, and Ken has started to develop tools to help people who are at end of life decide, that they are at end of life and maybe we should stop their stay in ICU. And he's developed algorithms now which do that. And I guess the question is, it's one thing to have an algorithm. It can very quickly move now to an AI, which would be very good at predicting death. In fact, we are actually very good at predicting in-hospital deaths, greater than 0.99 accuracy usually, for all sorts of interesting reasons. So we actually know who's going to die in a hospital pretty much. So is it okay for the AI to say a patient is at end of life, for us to follow that recommendation and withdraw care? Is it okay to perhaps do what the AI says and continue with care that might be futile? These are very difficult decisions. Why would you trust the AI to do that when there are very human reasons behind that? Is it okay in a natural disaster to have an AI do the triaging for us because we don't have the resources to do that? Or is it okay for AI to say who gets quarantined or who doesn't get quarantined? These are not questions that have easy answers, and in fact there's a lot of interest and activity in the whole issue of the ethics of AI in healthcare and more broadly. And I commend you to think about these issues and how they reflect your own practice. For me, in the end, it is all about the human being in the loop and the decision that's an ethical decision being one that we own, I think. But clearly there'll be circumstances in which we delegate at some point in the future. When and what we delegate is the question. Okay, let's now move to, I guess, the nirvana situation. Imagine that we've got AIs working with us, best of both worlds. It's smart, it can see millions of examples very quickly. You've got that fantastic broad reasoning capacity. You've got first principles. You can think through cause and effect in a way the AI can't. It sounds like a marriage made in heaven. What could possibly go wrong with with that marriage of human and machine. It's true. So we obviously already live in a world of machines that tell us what to do, and we do what we're told, and it doesn't always seem to work, does it? So this GPS example is a good one. And okay, hands up if you haven't done that. Made a mistake on the GPS. Yeah, we've all done it. Yeah. Actually, it's not my fault. My wife did it. Here's another example, which is the example of the guy in the Tesla who died because it had an accident, because he was busy watching Harry Potter because he was in hands-free mode and he thought that was fine. Tesla actually says keep your hands on the wheel. This is a driver assist. It's not autopilot. So this person trusted it too much. Interestingly, I saw a few articles recently about the 737 MAX crash. And they were saying, oh, that's AI. It's not. That was not AI. That was just incredibly bad design and bad safety practices. There was actually no AI involved. There was, having a safety critical system with one sensor, an unstable aeroplane that needed a computer to keep it operating. So that wasn't an issue. But anyway, so these two examples that I've given you here are examples of human complacency. Too much trust in the AI. And we have an academic term for it. It's called automation bias. And this is just our tendency to believe automation. In other words, we delegate trust and autonomy to the AI, to the computer system, because it usually works very well. And because it usually works very well, we take ourselves out of the loop and stop paying attention. It's also called automation-induced complacency. And there are many examples in healthcare. So we have seen examples, for example, in prescribing. There's a classic case from a couple of years ago in rural New South Wales in Australia. A GP prescribed a cocktail of drugs that were lethal. His defence was, the machine didn't tell me not to do it. That, of course, was not defensible. He was responsible for that prescribing act. And interestingly, of course, the alerts had been turned off anyway, so even if it had knew it was wrong, it wouldn't have told him. So this is the same issue. The decision support works very well. I trust it, and yet there are always going to be circumstances where it makes a mistake because context has changed, etc. So a big issue for us, and if we're thinking about training, then people need to be trained in the risks associated with too much dependency. So in general, not just with AI, but digital health has this big trade-off where, in general, it makes things much safer. We reduce errors, we improve efficiency, but we also always do increase harm, but new classes of harm. So the way to look at it is this, I think, where overall, any of these technologies which are well designed and well implemented will make things better, but there will be side effects, which are new side effects with their own harms. And if they are big enough issues, then they can really jeopardise the whole enterprise if they get on the front page of the newspaper, for example. The other thing that is risky is that although these risk events are rare, they can often be large scale. So whereas a clinician will often make one mistake with one patient, these technologies can make mistakes in batches of patients. So that's when something does go wrong, it might have quite a large impact. Okay, the next topic is one of my favourite slides, and apologies if you've seen this before. It says, this is where the design for our electronic record gets a little bit complicated. And I like to see this as a lesson, and it's a lesson in two things. This is work as imagined over here on the left-hand side. This is how the computer designers imagine clinical work happens. On the right is work as actually is done. So the real world is complicated, and we cut corners and we work around things and we make things happen. Things go wrong and we rectify them. Somebody hasn't turned up for shift, or a drug's not available, or a schedule's changed, and we adapt. And you just can't design that into a nice linear system, can you? And those issues don't just hold for electronic records or for ordering systems, they hold for AI too. So AI works for tasks as imagined or as captured in the data set. They don't really necessarily work for my patients as they are today. So the big message is that implementation, local context, shapes the outcome of the technology you have. As a researcher, I often get asked to review papers, and the typical response when I see a paper is, well, that's great with your neural network working on those X-rays in that province in China. How did it perform when you tried it somewhere else? And invariably, performance degrades, sometimes quite significantly. You know, it can go from 95, 96% performance to low 70s just by changing context. And that happens for all sorts of reasons. The realities are patients are different, case mix is different, work practices are different. All those things will mean that a system in one setting will not do well in another one. So I like to talk about the last mile, and whenever you hear talks about AI, I want you to think of this structure. So typically it starts with a great idea, let's solve this task with AI. Somebody says, we've got lots of data. I'm very excited. Let's use machine learning, they'll say. So then you'll hear the talk or you read the paper, and it will stop at the middle. I've got the data, I've built the model, I've tested it on the data, it works beautifully. What I want to see is the last mile. I want to see it implemented in the real world, in a different setting, and I want to see the outcomes improve. And there are only about 20 papers that have been published in the last 4 years that are actually RCTs in the real world. And not all of them are even large scale. So there's a real gap in our evidence that stops in the middle, which is what you might call in vitro, if you're a lab person. In vivo is still rarer. Having said that, those studies that do take mature technologies to the last mile have shown great results. So we're not saying it doesn't work, we're just saying that there is a pipeline, and before you get excited about something, make sure you know where you are in that journey. So I think I've said this, the same AI with the same inputs will give you different outputs in different settings. It's kind of a worry. And we need to understand that when we implement. And this brings us then to the broader context of it's not just technology, it's about ethics, it's about safety, it's about education. And these are all things that affect us, maybe as professionals, as colleges, or as clinicians, or in fact when we're training our doctors or our nurses. So here's just a summary of what I think are some of the questions you might want to ask yourself before you trust an AI. The first thing I would ask you to do is to, before you even look at the AI, ask yourself, what do I think is going on? What's my judgment? If you don't form a judgment, then you're at risk of automation bias. You'll just do what you're told. So it's always good to stay in the loop and to have a view of what you think is happening. The next one is, as I said before, to recognise that AIs are great at single tasks. And so make sure you know that the task the AI is now helping you with is one on which it's very good. It may not be as good on this one or on this class of patients. I really need new glasses. The next one is about explanation, and you probably, if you've been reading, have heard this many times now, which is that black boxes are not satisfying. You know, just because the deep learning system says something, it can't explain to you necessarily why. There are other classes of AI that are not neural networks that do have explanations, for example, and so it's always good, if you're not sure, to make sure there's explainability there. Another thing to think about is that you might know more about what's going on than the system. What data do you have that's external to the AI? You might know information about the patient that is not known to the system. It might be running off lab tests or images. You might know more about past history, about intention, about desires. And those things should reframe what's going on because you know more. If you're a Bayesian, that's called Bayesian revision. I've mentioned before the issue of bias, and is the patient in front of me representative of the population in which the AI was trained, or is this patient different? Another way of making the patient different is if they're multimorbid, because typically AIs are trained on single diseases, which have got clear classifications, and if you've got multimorbidity, as you know, pictures become much more complicated. Complex patients may not fit so well. And finally, and it's a subtle issue, but it's very important, is it might be that the way you collect data in your organisation is different to the way the data was collected elsewhere. So especially in imaging, machines are different, quality of images are different, workflows are different, and those subtle differences in the way images are created fundamentally alter the way the algorithm works. So you really need to make sure it's been tested and implemented and works at your setting. So let's turn now, I guess, to the future and where things are going. And for me, Amara's law is a wonderful way of summarising what's going on. We overestimate the effect of technology in the short run. Oh my God, AI is going to make us redundant. And we underestimate the effects in the long run. It's never going to change. I'm fine. The reality is it's in between, isn't it? That there will be changes, maybe not next week, but certainly in 10 years. So what I like to say is, maybe you won't see much change in your practice over the next 5 years, but you will definitely see fundamental changes happening within 10. And within 20, I'm pretty sure healthcare will be utterly transformed. And if there are trainees here who are thinking, where's 20 years take me? That takes you to just past mid-career. So for some of us who are going to exit soon, we shouldn't be too anxious, but there'll be big changes for people. And if you're a medical student, there are fundamental questions like, what specialty do I train in? Will we need to have radiologists in 30 years' time? I know the radiologists say yes. But just to say that people are already making decisions about their careers based on their guesses about where the technology is going. So this is already consequential. And I think one of the things that I find important is that there's a big issue around innovation versus safety. Especially with the US industry, they don't want regulation, they don't want certification because that will stifle innovation, they say. Yet the reality is we're in a safety critical industry and we need to be cautious in what we do. So I'm already seeing examples, and we go back to Babylon in London, where it's self-certification and self-regulation under the NHS rules there, which I find quite an uncomfortable situation. I think if we're going to be creating systems that have some kind of autonomy and change decision making, they need to go through bigger hoops than the developer says it's okay, tick. And I guess these last few dot points here are really just to get us to think about what will happen to the professions. Maybe in 20 years' time, I'm not a radiologist, but I'm actually a diagnostician. I don't just look at images anymore. I now integrate multiple sources of evidence and assist. I may not be in a darkened room reading images anymore. What happens when that little handheld ultrasound has an embedded AI in it and interprets images at the point of care? That changes the world too. So these disruptions can happen when we join two technologies together. So a lot of this is unexpected because these joinings of new technologies are unexpected usually. So I just wanted to finish with a sense of what we could be doing, and I just want to talk a bit about one thing that's happening back home is the Australian Alliance for AI in Healthcare, which has now only been around for about 12 months and only been formally launched quite recently. Recognising we're on the back foot in our country, we're nowhere near where countries like England are in terms of studying, investing and engaging with these technologies. We've got about 52 partners now, 5 of our state departments of health, many of the colleges, the radiologists, now the ophthalmologists, maybe today, after today, a few more will join, and lots of industry. And our interest really is to focus on translation, to not worry too much about building the technologies, Google will do that, but to understand what it means for clinical practice and what it means to safely embed it in clinical care. And I think, without going into the details there, one of our programs is around education. And the workforce program at the moment, we're thinking about 3 target groups. One is that we don't have the AI research workforce that we need in Australia. We're quite underpowered there. We have some fantastic scientists in the AI healthcare space, but not enough. We also need people who understand AI in terms of health services, to lead the innovation in the area, to be able to do it safely, to maybe not replicate the mistakes we've made with electronic records, and to do it more safely and effectively. And finally, to recognise that this is a fundamentally career-changing technology over the next 20 years for clinical practice. So to start to engage the professions in thinking about how they engage. And if you think about even a 10-year time frame, and I'm saying big changes will be here in 10 years, that's a very short period for a college to change its practice and its training programs. So I would argue that there's a lot to be done in a very short period of time. So Do we teach any of this in our undergraduate or MD programs? Probably not. We probably don't even teach digital health or electronic prescribing. That needs to change. Same for nursing, same for all the allied professions. So I think I just want to leave you with that sense of urgency. Yes, the train is still coming, but it's coming fast, and it's coming in ways that we don't understand. And I guess my message really is this, which is, so what is our fate? You know, will we all have jobs? I can't tell you, but I'll tell you this, that our fate is to change, and we will. Thank you very much.